metabolic disorders. The webinar of today is the first episode of series of 5 webinars. Today's activity is accredited by Saudi Commission for 2 hours CME. I would like, I have the pleasure to welcome our distinguished faculty headed by Dr. Fawzia Sharif, metabolic and genetics consultant, Saudi German Hospital, Dr. Huda Al-Khawaja, metabolic and genetic consultant at East Jeddah Hospital, Dr. Amal Al-Widiani, a consultant genetic and metabolic at Children and Maternity Hospital Al-Hifuf. I would like to introduce Dr. Fawzia Sharif to start our today's session. I hope that you will find this session is exciting and interesting and fruitful for all of you. Please provide your feedback by end of the session to help us to improve in our future sessions. Dr. Fawzia Sharif, please go ahead.
Thank you, Dr. Yasser. السلام عليكم ورحمة الله وبركاته. نبدأ الآن. الصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم. Today I'm going to talk about one of lysosomal storage disorder, which is mucopolysaccharidosis. The lysosome is an organelle in the cells that digest large molecules by hydrolytic enzymes. If there is any deficiency of these enzymes, leads to accumulation of these molecules. In mucopolysaccharidosis, we have a deficiency of some enzymes that degrade mucopolysaccharides at what we call glycosaminoglycan. The glycosaminoglycan is a chain of sugar with alternate highly sulfated urinic acid and hexamine. They play an important role at tissue level and at cellular level. At tissue level, they are a component of the cellular membrane, extracellular matrix, connective tissue, joints, fluids, and cartilage. At the cell level, they are important for cell differentiation, division, and communication. If there is deficiency of the enzyme that degrade this mucopolysaccharidosis or glycosaminoglycan, it will accumulate. And it has a primary effect and secondary effect. The primary effect, they accumulate in some organ, they cause organomegaly, or they accumulate in the soft tissue, for example, the respiratory system. The secondary effect, they have an effect of inflammation, fibrosis, and disruption of cell communication. So if there is reduction in the enzyme, they will accumulate and mucopolysaccharidosis will appear. Those disorders are very rare, estimated to be 1 in 20,000 live births. Because they are very important disorder and they are very progressive and debilitating and life-threatening, and there is some treatment for some of those disorders. It's very important for early diagnosis and detection, because if we diagnose those cases early, we can manage early and we can relieve some of the symptoms they have. So the optimal pathway for diagnosis is clinical suspicion. If the physician has high clinical suspicion, he will detect some of the signs and symptoms of those disorders, refer it to metabolic and genetic consultant, then for further investigation for confirmation of diagnosis and starting treatment. It is important to know that the primary caregiver, and we call them the medical home, they are the first physician to usually to see this patient at the beginning. And they should be aware of the symptoms and signs of those disorders for early transfer or referral to medical genetics or metabolic consultant or specialist for further investigation. So here comes the importance of primary health care for detecting such cases. We usually have the flow of cases for me as a metabolic physician from primary health care. Usually those patients with mucopolysaccharidosis, when they are born, they look normal. But when the time passes, they start to have the symptoms, mostly coarse features. And here, if you notice here, at the age of 10 months, patients start to have some coarse feature, increasing in severity at the age of 12 months, and so on, until here, at the age of 39 months, the patient have full-blown picture of the disorders. Very coarse feature, and you can see he's using oxygen because of the effect of glycosaminoglycan on the respiratory system. Here, the symptoms, clusters of symptoms that the patient might present. The presentation of organ involvement, it varies with the phenotype. And not all the patients present with all the clusters of symptoms, because in mucopolysaccharidosis, we have variation from very severe type to attenuated type. Patients may present with cognitive impairment. They present with macrosomia, hydrocephalus. They have obstructive airway disease, corneal cloudiness. They have coarse features. They might present with ENT problem, otitis media. They usually have a large tongue, and they have some bone problems. They might have kyphosis, joint pain, and contractures. In some cases, carpal tunnel syndrome, and they may be too walking. They have usually cardiac defects, cardiovascular disorders with valvular enlargement. They have organomegaly, hepatosplenomegaly. They usually have hernia. So detection of any of these symptoms should raise the bell that the patient should be further investigations to confirm the diagnosis. The mucopolysaccharidosis, we classify them into from type 1, type 3, type 4, type 6, type 7, type 9. MPS number 5 formerly was called She syndrome, and number 8 no longer are recognized. They are not recognized anymore. Most of them are autosomal recessive except type 2, which is X-linked recessive. In type 1, type 1 and type 2 and type 6, deficiency of enzyme leads to increase of dermatan and heparan sulfate. This is the glycosaminoglycan. In type 3, they have increased heparan sulfate. In type 4, they have increased keratan accumulation of keratan sulfate. In type 7, dermatan sulfate. In type 9, they have increased glucuronic acid. We usually group them into 4 groups to differentiate between them, to make it easier for us to understand the disorders and to suspect what kind of disorders the patient is suffering. The one who present with soft tissue storage and skeletal disease with or without brain disease, this is in MPS 1, 2, and 7. The one with soft tissue and skeletal disease, only soft tissue and skeletal, without brain disorder, this is MPS 6. The one with primary skeletal disorders, they come with skeletal abnormalities without soft tissue involvement, this type 4, A and B. The one who present with serious manifestation without somatic manifestations, those are type 3. So again here, a summary of what I have said. The difference that type 3, they usually present with central nervous system abnormalities. Type 4, they present with joint laxity and hypermobility. The opposite of the other types, they present with joint restrictions of movement. Because those disorders are very severe, life expectancy is reduced in most of the cases if they are not treated. For example, MPS 1, they might die within the first 10 years. MPS 2, they usually die at teenager without treatment. Taking in consideration that those disorders may run either very severe and very mild. The mild one, the attenuated type, they present with usually with lesser symptoms. How do we diagnose those cases? Usually when we have cluster of symptoms, we start with doing an X-ray. We find what we call diastosis multiplex. Then we do urine glycose aminoglycan screening to see if there's an abnormal increase. We confirm this by enzymatic assay, and after that, we confirm it by DNA testing to know the type of mutations. For genetic counseling, how do we treat those patients? Usually, they need regular assessment and multidisciplinary treatment. Refer them to orthopedic, ENT, cardiovascular physician, all physicians. We can send them for better treatment and for better management. They need very regular assessment. There are two ways of treatment, either hematopoietic stem cell transplantation, which is, we should start it very early, because if we start it early, it leads to stabilization in upper airway and respiratory function, hearing, vision, cardiac function, hepatosplenomegaly, and joint mobility. The facial features, the coarse feature will be reduced, but there are certain abnormalities that has to be dealt with, like cloudiness of the cornea, cardiac valvular abnormalities, and skeletal abnormalities. It has to be dealt with with the special physicians. And the transplant, hematopoietic stem cell transplant, it doesn't reverse the intellectual abnormalities that the patient developed. So it's very important to start it before any intellectual abnormalities develops. The second treatment is enzyme replacement therapy. It's the same. We have to start very early to get benefit of the treatment and to avoid complications of those disorders. Looking forward, because enzyme replacement therapy and stem cell transplant is to relieve some of the symptoms, but they are not curing the disorder. Inshallah, in the future, we are looking for therapy that cure the patient. I'm going to present some story of my patient, real patient, my patients, to show how different each patient presents. I have for MPS 1, I took the permission from the family to present those cases. For MPS 1, I have Ahmed, Dima, and Dana. For MPS 4, I have Ali and Tala. And for MPS 6, I have Yasin, Firas, Suha, and Khulud. I will start with Ahmed. Ahmed, he was the first patient I seen when I finished my fellowship. They referred the case to me as a consultation. He had several admissions to the ICU, to the hospital. Many times he spent around months in the ICU. So when I saw the patient, he was at the age of 10 years. He was dysmorphic, coarse feature, large head, joint restriction of movement, short stature. So at that time, I thought of mucopolysaccharidosis. I did an X-ray, showed diastosis multiplex. I did urine glycose aminoglycan, it was abnormal. Then enzymatic assay and confirmed it by DNA testing. Then after that, I started treatment. Ahmed, actually the first patient in Ministry of Health to start enzyme replacement therapy in Kingdom of Saudi Arabia with the help of his father. He was working at Ministry of Health. We started enzyme replacement therapy weekly. The patient, at that time when we started, he was in ventilator. He improved a lot after 3 months. He was out of ventilator, but he had tracheostomy tube. He was discharged. After 1 year, the tracheostomy tube was closed. He did very well for 2 years. Then a time came when he developed a chest infection, and his father took him to another hospital, not to our institute, and unfortunately he died there. So this one who present with fully blown picture, severe type of MPS 1. The second patient is Dima. She referred to my clinic at the age of 3 years with history of repeated attacks of ear infections and some joint restrictions of movement. When I saw her, she was not dysmorphic, only very mild coarse features. She had mild hepatomegaly, she with normal mentality, normal motor development. So again, I thought of storage disease. I did an X-ray, showed diastosis multiplex. I did abdominal ultrasound, showed hepatomegaly and mild calical system enlargement. Enzymatic assay was low for alpha iodronidase, and I confirmed this with DNA testing. We showed mutation, showed coding DNA replacement of guanine by adenine. And she was homozygous mutation for arginine replaced by glutamine. So she was homozygous mutation for MPS 1. She received treatment, enzyme replacement therapy every week. She's doing just fine. She's around 12 years old. She's going to school, very smart girl. Her problem is the joint problem. Still, she's having very restricted joint movement. Did not improve with the treatment. Her sister Dana, she was presented to me. I screened her when she was born, and I found her that she's carrying the same mutation. The enzyme is low. And I was planning to do a stem cell transplant for her, but unfortunately, we could not do it. So we started enzyme replacement therapy for her. She started enzyme replacement therapy. Now she's going to school. She's a smart girl. Again, she is still having restriction of movement. This mutation is related to attenuated type of MPS 1, the mild form of MPS 1. Then we screened the whole family, mother, father, and another sibling were carrier for the same mutation. This is Dana. Again, I took the permission to show her pictures. If you can see, her joints are very restricted. I tried to refer to orthopedic, but most of orthopedic in our area, they don't have a lot of experience with those cases. So inshallah, in the future, we'll have someone who can help us, help those patients for their this problem of restriction of joint movement. MPS 4A, I have 2 patients. I have actually a family of 5 patients, but I'm going to present 2 of them. Ali, he was referred to my clinic with genovalgum, scoliosis, protrusion of the chest, mainly skeletal. When I saw him, he was short with no somatic coarse features, only those abnormalities of skeletal manifestation. So at that time, I did suspect mucopolysaccharidosis. I did an X-ray and enzymatic assay. X-ray showed metastasis multiplex again. Enzymatic assay was undetectable level of N-acetyl galactosamine, 6-sulfatase. DNA showed deletion on the gene. So he was confirmed for MPS 4 type 1A. Again, I saw Tyler. After I was confirmed, I suggested a family screening. So I diagnosed 5 of them as MPS 4. Now they are receiving enzyme replacement therapy. They are in the south. Sometimes they are missing their enzymes replacement. Now they are moved to the south of Saudi Arabia, receiving their enzyme replacement therapy. MPS 6, I have 3 different stories. Yasin, he referred to me at the age of 6 years with typical signs and symptoms of mucopolysaccharidosis, short stature, cloudy cornea, severe coarse features, umbilical hernia, hepatosplenomegaly. He had normal speech and normal mentality. At that time, I thought of mucopolysaccharidosis, but type 6 because they don't have CNS involvement. I did investigations again and confirmed the diagnosis by enzymatic assay and DNA testing. We started giving Yasin enzyme replacement therapy. He's fine, he's okay. He can walk. The coarse feature decreased a bit, but still because we started at the age of 6 years, it was a bit late. But he's stable now. We have Firas, this different story. The patient referred to me as a case of MPS 4. He was diagnosed in Jordan. He and his cousin diagnosed, they presented with scoliosis. When I examined them, I found there is no joint restriction, only joint hypermobility. So I thought this is not the sign of MPS 6. This is the sign of MPS 4. And we did enzymatic assay and show low level of aryl sulfatase B. Sorry, this is type 6. We find joint restriction. They diagnosed as type 4, but when I found joint restriction, I diagnosed the case as type 6. I started enzyme replacement therapy, and the patient is doing fine on enzyme replacement therapy every week. His cousin saw her again. She was diagnosed as type 4. She had several surgery for her spine because she had a restricted type of movement, Okay, this is not a type 4 because they have hypermobility. This is a type 6. I did enzymatic assay. It shows a low level of aryl sulfatase, and did DNA testing. So at Y251X protein, which is very common for type 6. I have Khulud. Khulud has different story. Her older sister is medical student. She was noticed that her sister is having coarse features. So we did, she recommended the case to be presented to me as a metabolic physician. And we investigated her and we confirmed the diagnosis. And she showed low level of aryl sulfatase B. And DNA testing showed at coding level of 724, replacement of cytosine with thiamine. She was a heterozygous for protein mutations, and this is confirmed the diagnosis. We started her on enzyme replacement therapy. She's doing just fine, improving. And I presented those cases to show that every case, they present different from the other. So we should have high clinical suspicion of such cases for referral and early treatment. And this is the end of my talk. Thank you so much. Okay, now Dr. Amal Widainani, she's a consultant of metabolic genetic at East Jeddah Hospital. She is going to present her speech with the case of Gaucher disease. Cases of Gaucher disease. تفضلي دكتورة أمل.
I cannot share the screen, Victoria. You can hear me?
Yes.
I cannot share the screen because you are still there.
Okay, I will close. Okay, دكتورة أمل. تفضلي دكتورة أمل.
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Fawzia, for invitation and this brief introduction. I will start my topic to think outside the norm. It's rare disease. I will go through the outlines, introduction, types, and diagnosis and treatment for Gaucher disease, which is a metabolic disease. Firstly, I will talk about the structural population of Saudi families, which impact increasing of autosomal disease in our society because of large size of Saudi female families members, average 6 members, and we have limited preliminary screening program, which is screening about the thalassemia and sickle only from inherited disease, and increased incidence of consanguineous marriages more than 60%, and we have growing population 33 millions. This is a map of international showing the consanguineous marriages done by nature. You can see here in our country more than 60%. So rare, it doesn't mean cannot be existed according to these factors. So I will share one of my patients. She's 5 years old, a girl presented with progressive abdominal distension. It's a hepatosplenomegaly by clinical examination. Initial investigation showed pancytopenia, and otherwise she's healthy. This is my patient. I took the permission from the patient. You can see the abdominal distension, huge abdominal distension with full flanks, and you can see abdominal veins visible. It's turned out Gaucher disease type 1. And this is the usual presentation of Gaucher disease. So Gaucher disease, the pathophysiology, it's decreased enzyme activity of glucocerebrosidase. And it's because if this enzyme can cause degradation of glucocerebroside to the ceramide and glucose. If there is any deficiency, it will accumulate this product, it's toxic product. So Gaucher disease, it's progressive, chronic, heterogeneous, multisystemic, and sometimes life-threatening. So glucocerebroside, it's accumulates mainly in macrophage. And we know macrophage in spleen is a tissue macrophage, and lung alveolar macrophage, and bone osteoclast, and liver Kupffer cell, and bone in bone marrow. If you know the mechanism of the disease or pathophysiology of the disease, you can know the clinical manifestation of this disease later. So this is the macrophage. You can see the lysosome. This is a normal lysosome, a normal macrophage. And this one, it's abnormal macrophage with a swollen lysosome and swollen macrophage because of decreased activity of the enzyme. The prevalence of Gaucher disease is 1 in 100,000, and the annual incidence of the Gaucher disease in general population 1 in 60,000, and in Ashkenazi Jewish it's 1 in 1,000. This is a statistic done by Australia. You can see the Gaucher disease is the most common of lysosomal storage disease in the Australian population. And this one statistic done in our country in Eastern Province, you can see the lysosomal storage disease most common, the lipidosis. And here the distribution of lipidosis in Eastern Province, it's 3% Gaucher disease. But in our region, it's common, quite common, Gaucher disease. So Gaucher disease is autosomal dominant, autosomal recessive. Both parents are carrier for Gaucher disease. 25% of the child can have a Gaucher disease each pregnancy. Also, the most common mutation in GBA gene, and more than 95% other mutation we have also. Now I will talk about the types of Gaucher disease. We have 3 types, type 1 and 2 and 3. So type 1, absence of primary central nervous system disease. This is the characteristic of the type 1. They can manifesting by bone disease, hepatosplenomegaly, pancytopenia, and lung disease. Type 2 and 3 can be manifested by presence of primary neurological disease. Type 2, the onset before 2 years, as limited psychomotor development as a developmental delay, and rapidly progressive course with death by age of 2 years or 4 years, and classified as acute form. Type 3 also have onset before 2 years, but quite slowly progressive, and survival in the 3rd or 4th decade, and it's subacute form. Type 3, we have subdivision. We have prenatal lethal form associated with ichthyosis, or we can call it collodion baby, or non-immune hydrops fetalis. And the cardiovascular form, which manifesting by calcification in aortic and mitral valve with mild splenomegaly and corneal opacity and ophthalmoplegia. This is non-immune hydrops fetalis and the colloidal baby. So type 1, it can be manifesting, as we said, bone disease. 70 to 100% of the patient affected by type 1 can have manifestation of bone disease. It's like subchondral joint collapse with secondary degenerative arthritis, focal lytic or sclerotic lesion, acute or chronic bone pain, asymptomatic osteopenia, pathological fracture, osteonecrosis. And this is the shape of the long bone in type 1 Gaucher disease. It's a flask shape deformity. Type 1 can be manifested by hepatosplenomegaly. It's increase in size up to 3,000 cc size more than adult size of a spleen. They can have hypersplenism with pancytopenia, infarction of the spleen. Liver enlargement is common, although cirrhosis and hepatic failure are rare in type 1. Pancytopenia, universal if untreated Gaucher disease. Pulmonary involvement, interstitial lung disease, alveolar lobar consolidation, pulmonary arterial hypertension. So they are prone to the malignancy, multiple myeloma, hepatocellular carcinoma, non-Hodgkin lymphoma, and malignant melanoma with pancreatic cancer. Also, they are prone to moderate to severe psychological complication as a depressed mood or somatic concern. Cholelithiasis is one of the manifestations on adult with Gaucher disease. And this is the picture, summary of the clinical manifestation of Gaucher disease type 1, pathological fracture, collapsed vertebrae, flask-shaped deformity, pancytopenia, osteopenia, and osteonecrosis with hepatosplenomegaly and bone crisis. And this table, it summarizes the clinical manifestation of all types. You can see all types is manifesting early in childhood. Ichthyosis only find in the type 3 prenatal lethal, hepatosplenomegaly in all types almost, bone crisis in all, most of the types, type 1 and 2, and 3A and B and C. Cardiac calcification only in 3C, type 3C, and neurodegenerative disease in all types except type 1. Survival in type 1 is variable, and also type 2, and type 3 less than 1 month in prenatal lethal, and the other types classical, which is juvenile, less than 2 years, and the other 2 and 4 decades of life. All of them in pan-ethnic. Now, how can we diagnose the Gaucher disease? By the gold standards test, which is enzyme assay, can be done in leukocyte peripheral blood or culture fibroblasts, skin biopsy. Enzyme activity usually to be diagnosed as Gaucher. In adults, usually they have 10 to 30 of normal activity of the enzyme, or children severe cases less than 10 of the normal activity of the enzyme. DNA analysis is reliable for the carriers and the affected also. This is the filter paper. We can take dry blood spot to measure the activity of the enzyme, and also for DNA testing. This is bone marrow aspirate. You can see the Gaucher cell, which is a swollen macrophage. So why it's important to pick up the cases early? When left untreated, Gaucher disease is most often associated with progressive morbidity. Also, increased recognition and early diagnosis may allow the initiation of appropriate treatment with ERT. So also, we can do the genetic counseling by screening the carrier status, also detect the other affected members early, and prevention measurement like BGD and prenatal screening. How to treat? We have 2 modalities or 3 modalities to treat Gaucher disease. So general principle, phenotypic severity depend on residual enzyme activity and also depend on substrate accumulation. So early onset, very low or absent activity, extensive substrate accumulation, severe manifestation, this is the rapid course. Late onset, more residual activity, less substrate storage, and more subtle, slowly progressive disease. So based on the provision of sufficient exogenous enzyme to which break down the glucose trophocyte. We have 3 types of the enzyme replacement therapy, but available Cerizyme. We can give Cerizyme 60 international units per kg every 2 weeks, lifelong. So ART, enzyme replacement therapy, is well tolerated. They have up to 15% of individual developed antibody to infused Cerizyme. Other like allergy reactions, we can deal with it by premedication antihistamine. We can use enzyme replacement therapy to Gaucher disease type 3. Also, the sublink with patients with having chronic neuropathic and proving Gaucher disease, and onset of severe systemic Gaucher disease at age less than 2 years, and also high-risk genotype like these genotypes. We can treat the Gaucher disease type 3 also by 60 units per kg every 2 weeks until adulthood, until the mild Gaucher disease symptoms stabilize with the neurological involvement. Then we can reduce the enzyme dose. The outcome, individual with type 1 report improve in health-related quality of life after 24 to 48 months of ART. After prolonged treatment with ART, reduced the rate of bone loss in dose-dependent manners, improve bone pain, and reduce bone crisis. So the pros and cons of ART: pros, its few side effects, long drug history in the market with wider availability. Cons, inconvenience, because every 2 weeks they can come to the hospital to take the dose, more invasive. The other modality, substrate reduction therapy, is partially block the body from the producing glucose riboside, the fatty chemical that build up in the body of the patient with Gaucher disease. One of them is miglustat, is the first oral agent for the treatment of individual with mild to moderate Gaucher disease. Miglustat resulted in significant decrease in liver and spleen volume after 6 to 18 months, with a clinical improvement noted over 24 months. Bone involvement and platelet and hemoglobin values remained stable or were more improved. So what is the pros and cons of SRT? Pros, it's convenience, less invasive, consistent dose, which is 100 milligrams twice daily. And cons, there is a side effect like neuropathy, drug interaction with antibiotic and cardiac drugs and antidepressant, also the adherence of the patient. This is a picture shows the enzyme replacement therapy effect. You can see it's degradation of GL to ceramide and glucose, less toxic. And SRT can inhibit the enzyme synthase to do, which is produce GL, which is a toxic product in the body. By slowing producing of GL, the remaining activity of the natural enzyme in our cells can break down the products, toxic products in the cells. So the other modality, it's bone marrow transplantation. Can we use it? The individual with chronic neurological Gaucher disease or progressive disease despite of ART or SRT may be candidate of BMT. So there is clinical trials in the Gaucher disease, like gene therapy, and it's still on the animal models, and it's successful in the animal models. It's not in human. So in summary, Gaucher disease is potential life-threatening, progressive, multisystemic, heterogeneous, and inherited disease. Type 1 Gaucher disease is treatable disorder. Raise the awareness among the doctors to reach out early to such cases. An enzyme assay blood test can help in diagnosis. Early diagnosis and initiation of treatment offer significant clinical benefits. And this is the picture of my patient. You can see this is the previous one before the enzyme replacement therapy. This is after 6 months of the enzyme replacement therapy. And now she's 10 years old, she's getting better and is still on the enzyme. And this is the website that can help you to have information about the Gaucher disease. Thank you.
Thank you, Dr. Amal. Actually, Dr. Amal, she's a consultant pediatric, metabolic and biochemical genetics consultant. Currently, she's a clinical and biochemical genetic consultant in pediatric department, East Jeddah General Hospital. Thank you, Dr. Amal. Our next speaker is Dr. Huda. Dr. Huda Al-Khawaja. She is a consultant metabolic and genetics. in Al Hafuf Al Hassa Hospital. She got her Arab board in 1998, medical genetics. She had her fellowship in 2002, 2001. She's an assistant professor at King Faisal University till 2017. She's a chief of medical genetics department in MCH Al Hassa, coordinator of a newborn screening program. She's going to talk about one of the lysosomal storage disease with Fabry disease. Dr. Hoda.
Thank you, Dr. Fawzi, for that introduction. And I would like to thank the organizing committee for the invitation. Fabry disease, and thank you for Dr. Ahmed because she gave introduction to the lysosomal disorder, and she discussed the Gaucher disease, which is equal to 3% of the lysosomal disorder. As we can see from her slide, Fabry disease, 23% of lysosomal disorder. I will discuss the background of Fabry disease. I will discuss inheritance and epidemiology, pathophysiology, lysosomal storage disorder. Then I will go in deep clinical involvement because it is underdiagnosed. So we should know all the clinical sign and symptom and all the manifestation of the disease. Diagnosis, how will diagnose disease, treatment, and in summary. Fabry disease is a progressive life-threatening disease. It's one of the most common lysosomal storage disorder, and the prevalence is 1 in 40,000 in male and 1 in 20,000 in female. The incidence approximately 1 in 170,000 live birth because of underdiagnosis. A mutation of galactosidase alpha gene on the X chromosome causes alpha galactosidase A deficiency. More than 600 mutations described worldwide, mostly private or single families. This causes pathological accumulation of GB3. Actual incidence and the prevalence, I said, may be underestimated. Fabry disease is difficult to diagnose. The true incidence and the prevalence of Fabry disease are unknown. What is Fabry disease? It is under-recognized X-linked recessive lysosomal storage disorder known as Anderson-Fabry disease. It's a progressive, ultimate, life-threatening, characterized by deficiency of lysosome enzyme alpha-galactosidase A. Deficiency of that enzyme lead to progressive accumulation of a globotriacylcyramine. This will lead to vascular endothelium and physical tissue throughout the body, accumulating end organ impairment because of the deposition of GB3. This is the pathway, the deficiency of the enzyme, because of the gene is deficient, it will not convert the GB3 into the component. So there is accumulation of GB3 in the vascular, the lysosome, which is responsible for endothelial, epithelial, and the smooth muscle cell of blood vessels. So that defect gene encoding alpha-galactosidase A will lead to deficiency of the enzyme, and if the enzyme is less than 1%, so it will lead to progressive multisystemic lysosomal accumulation of GL3 or GB3. This will lead to GL3 filled lysosome, so will give us organ failure. So the Fabry disease starts here. This is the cell, and this is the lysosome. Lysosome is the digestive system of the cell. It's the broom of the cell. It will clear all things from here. And also it will break down molecules into their base component with a strong digestive enzyme. So if the lysosome not working, so the sphingolipid will accumulate in the lysosome and it will destroy the cell, and the cell will destroy the tissue, and the tissue destroy the organ, and we will have end organ failure. We can see here also, this is the glycophospholipid. If we have the enzyme in normal ratio, it will degrade the phospholipid, and it will give us normal cell. If the enzyme is deficient, we'll have deposition of glycolipid inside lysosome, inside the cell, will give us with abnormal cell. The extent of accumulation typically differ among cell and tissue types. The progressive pathological cellular and tissue change result in varying degree of end organ damage in most Fabry patients. Organ systems most profoundly affected are kidney, heart, and brain. Expression of the disease in male and female is variable. As we said, it is X-linked recessive. There is no male-to-male transmission. And symptomatic female, if she's heterozygote female, she will experience some symptoms to very degree if she's because of lionization theory. It's pan-ethnic. The prevalence, as we said, it is 1 in 40,000 in male. Studies suggest that milder form of disease, which present later in life and usually affect the cardiovascular system, might be more common and may be underdiagnosed. How it's inheritance? If the mother is the affected or carrier, she has 50 risk of passing defect gene to sons and daughter. 50% of her affected son and daughter, they will be affected. The son will be affected, the daughter will be carrier or affected. And also the 50% of them will be normal. Here, if the father is the one who's affected, you can see there is no male to male transmission. And his daughters will be either carrier or affected. So he passed the defect gene to all of their daughter, none of the sons. So all his daughters are affected and the sons are normal. Cellular dysfunction, Fabry disease is characterized by a glycophospholipid accumulation within lysosome in specific cell types. In vascular endothelium, in cardiac myocyte, and renal glomerular tubular epithelial cell, in neuron of peripheral, cardiac, autonomic, central nervous system tissue, variety of skin cell, cornea, stroma cells also. So the key pathology, lipid deposit in vascular endothelial. This is the main reason for all the symptoms that present the patient with Fabry disease. So clinical manifestation, and we will go deep in clinical manifestation because it is difficult to diagnose or to suspect the patient with Fabry disease. They will include renal failure, cardiomyopathy, cerebrovascular accident. If we see any undetermined cause of renal failure, heart failure, or cerebrovascular accident, we should look for Fabry disease. Progressive accumulation of GLO3 result in variable but progressive involvement of multiple organ systems. The average life expectancy is 50 years only, so it will decrease the life expectancy. Fabry disease is a slowly progressive pathology, and in early life, they will have early symptoms, and there is little accumulation of GB3. They will present by pain, GI symptoms, hypohidrosis, cold heat intolerance, and impaired quality of life. As the GB3 storage will increase in the third and fourth decade of the life, we will have other tissue involvement and organ failure. The late complications include renal failure, cardiovascular complication, CNS complication, and death. We see here the beginning of the age will start with acrobarethesia, which is the early symptoms. Then slowly will progress disease till the second and the third decade of the life. Then CNS manifestation between 30 and 40 years, then cardiac disease at 40 years, and the constitutional symptoms, it will be normal in the beginning, then it will decrease the quality of life, the constitution symptoms. And the quality of life, at the beginning it will be normal, then it will be decreased. This slide shows the various variant phenotype. We have a classical severe type and variant mild phenotype. The severe type, no detectable enzyme because it will be less than 1%. Symptom affect multiple organ system. Common mutation individual with the classic phenotype include large and small gene rearrangement, splicing defect, missing or nonsense mutation. The mild phenotype, they will have late onset with some residual function activity of alpha-galactosidase A because it is mild, so we have some sort of enzyme still active. Symptoms are generally restricted to cardiac anomalies. A mutation are typically splicing defect or missing mutation. The spectrum of disease and the organ which involved in the Fabry disease, and we will discuss each one in details. The eye will be affected. They will have cornea verticillata, they will have hypohidrosis, they have cardiac complication, peripheral neuropathy, angiokeratoma, GI dysmotility, renal complication, hearing loss, early stroke, and psychosocial issue like depression. In female patients, the woman with Fabry disease may be as severely affected as men. Symptoms change and progress throughout the life. Usually the female present with the neurological symptoms. It is the earliest symptoms. Around 77% of the women, they will have neurological symptoms. Cardiac signs also occur in 59% of the women. Gastrointestinal symptoms are more common in women than in men. Symptoms generally appear at 6 years later than in men. So the men will appear earlier than women. In childhood, they will present mainly by episodic of pain crisis, hypohidrosis, corneal and lenticular obesity, recurrent fever, heat and cold intolerance. During adolescence, they will have more common angiokeratomas and fatigue. Adulthood, they will present with renal dysfunction. This is the early symptoms for them in adult life. Neurological complication, cerebrovascular disease, cardiac dysfunction, and hearing loss and tinnitus. Neurological manifestations include early stroke, hemiparesis, diplopia, dysarthria, nystagmus, nausea and vomiting, vertigo, head pain, and hemiataxia with ataxic gait. The pain in Fabry disease or acroparesthesia, it's constant beginning in the first decade of life. It will start early and it will disappear gradually later. Affect hand and feet, it's like burning sensation. They will say, I feel there is fire in my hand and feet. Describes as burning, tingling, pain, and discomfort. Triggered by fever, heat, physical exercise, fatigue, stress with the weather change. It's unresponsive to narcotic, analgesic, unless if it is chronic, caused by small fiber neuropathy. Early signs and symptoms or other feature of Fabry in small fiber neuropathy. We will have dysfunction of autonomic nervous system, which will lead to gastrointestinal dysmotility. They will have postprandial abdomen cramps and diarrhea most commonly. Also, they will present by hypohidrosis, may also be result of dysfunction of sweat gland due to GLA accumulation in the small fiber of neuropathy of the sweaty gland. Reduce saliva and tear formation, a change in cerebrovascular circulation, reduce orthostatic cardiovascular control, all because of the position of sphingolipid in the small fiber. This picture, it shows brain abnormality. Here we can see, here we have cerebellar infarct. We have here white matter lesion in 44% of patients. Here we can see tortuous dilated vessels. Ocular manifestation, we have two types, anterior and posterior. Here we can see from this picture, we can see corneal and lenticular opacity. It's horror-like cornea rays, only visible by slit lamp, vision usually unaffected. Also called corneal verticillata. Here we can also see the abnormal, the manifestation in the ocular, in the conjunctiva, and also in the retina. We can see here vascular lesion, it's sausage-like, it is dilated vessels. We can see it in the conjunctiva and in the retina. Dermatology manifestation, mainly angiokeratomas. They are patchy trunk distribution, non-blinching, dark red to blue-black maculopapular lesion, appear in adolescent and worsen in adulthood. Hypohidrosis or anhidrosis is result from to lead to heat and exercise intolerance caused by endothelial cell filled with GL3. This is angiokeratoma in the skin and also in the mucosa. We can see around the lips. It's mainly around the umbilicus and the thigh also. Now cardiac manifestation, they will present by conduction abnormality, arrhythmia, left ventricular hypertrophy, myocardial ischemia and angina pectoralis, valvular disease including mitral insufficiency. They can present by congestive heart failure, and also coronary artery disease has been reported in some cases. We can see here marked thickening of myocardium of left ventricular hypertrophy in women with 50 years. Renal manifestation, I will not go deep in renal manifestation because there is renal manifestation of Fabry disease in the subsequent lectures. Progressive renal insufficiency, they will present by proteinuria, azothenuria, azotemia, elevated serum creatinine level. They will have also end-stage renal disease. They need dialysis and transplantation. Most frequent cause of premature death among male Fabry patients. So the male patient will present with renal manifestation. Histology of the renal complication, they will have progressive glomerulosclerosis, tubular atrophy, renal tissue fibrosis. All this will lead to overt proteinuria, progressive decline in glomerular filtration rate, hypertension, and end-stage renal disease. This show, you can see here atrophic and the hyalinization of glomeruli in patient, biopsy for patient with Fabry disease in renal tissue. Here we can see this black, you can see inclusion of body of glycolipid in podocyte. This is the picture of patient with Fabry disease in this stage, Fabry kidney disease. Gastrointestinal manifestation, as we mentioned earlier, it can be because of neuropathic, and it can be also they can present by postprandial abdomen pain, cramps open with debilitating diarrhea. It begin in childhood or adolescent. They will have weight loss or lack or weight gain. It's associated with nausea, vomiting, and morphological change in large and small intestine if you did X-ray. All this because of accumulation of GL3 in autonomic ganglia of bowels and intestinal vessels. Other findings in Fabry disease: fatigue, lymphedema, decreased quality of life, impaired social functioning, pulmonary abnormality, growth retardation, delayed puberty, depression, change in joint and bones, impaired fertility. This patient, this is coming slide for patient of Dr. Nouria Sanna. She's working in Aramco Hospital. Now it's known as John Hopkins. I took permission to use her patient. She has family with very big family with Fabry disease, and I inherited from that family 3 patients. So the index case for Dr. Nouria was a patient present at the age of 17 years, referred to nephrologist for persistent proteinuria for 1 year. So the case was diagnosed by the nephrologist, not by genetist. He has history of headache and blurred vision. Brain CT scan shows sclerotic lesion. Renal function and ultrasound was normal at the time of diagnosis. Renal biopsy show extensive vacuolation of epithelial cell with myelin bodies deposition, irregular shaped zebra body, myelin body in the endothelial cells. It's consistent with Fabry disease. And this is the pedigree of the family at the start. And this is the proband. This is the patient. When they secrete the family, they discover 6 female carrier. The mother was carrier. Here he has also 5 sisters are carrier, and one of his brother is affected. One of them not affected. She diagnosed by leukocyte alpha-galactosidase activity. It was between 0.37 and reference range was 0.6. And also she did the direct mutation analysis of GLA gene. It came positive. A disease-causing mutation, G373D. They referred to metabolic surface for possible enzyme replacement therapy. And she evaluated the patient neurology by baseline MRI, brain MRI, ophthalmology. She did all the baseline investigation for the patient, including ophthalmology, cardiovascular, and renal. And she monitored the patient by adverse. She started also enzyme replacement, enzyme therapy, and she saw that she noticed adverse reaction. Generally, they are well tolerated, and this is a reaction of the patient. And biochemical study, she is doing serum and urine GL3 and the clinical evaluation. This is a patient before treatment. He has edematous face. And this patient, the same patient after enzyme replacement, he improved. This is she put cannula for renal dialysis, for hemodialysis, and because of the vessels is there is deposition of sphingolipid in the fizzles. It causes dilatation and tortuosity of the fizzles. Again, the same pedigree of the same family. One of his daughter married one of their relative, second degree or third degree, and she has two daughters. They are asymptomatic, and one son has the disease. I inherit all this patients because they are eligible for treatment in Aramco Hospital. So the whole pedigree, they have total female, 6 female, and 3 male affected with the disease. And this is the patient demographic data done by Dr. Nouria. And this is the latest pedigree. I inherit Saif. I inherit his sisters plus that one. So this is Saif. I took his permission to show his picture, and this is his enzyme level. It was low, and we did for him molecular genetic testing. It was positive. Till now, we request for him the enzyme. Till now, we didn't start the treatment. The specialist to work with patients with Fabry disease, the genetist, neurologist, ophthalmologist, dermatologist, and nephrologist. Why it's important to screen the Fabry disease in women? Because they will not show the symptoms. So female carrier for Fabry disease exhibit a range of clinical phenotype. It can be asymptomatic to as severe as male, cannot predict timing of onset or severity of the disease. Lionization affect interpretation of enzyme level SA. If the enzyme is deficient, it's indicate Fabry disease, but we have to do genetic testing. If it is normal, does not exclude the diagnosis. We have again to go again to do the genetic testing. Positive diagnosis can be made by mutation analysis. We are investigated Fabry disease by screening female. We can use GL3 accumulation in the urine and in the plasma. So the clinical impact of Fabry disease, renal impairment seen in approximately 84% of patients. Cardiac disease is reporting up to 69% of patients, and it's a major cause of death. Cerebrovascular manifestations are reported up to 72% of Fabry disease patients. Diagnosis of Fabry disease, patients typically are referred to several specialists before definite diagnosis. Misdiagnosis and diagnostic delay are common, which can result in progressive irreversible tissue damage. If a clinical suspicion of Fabry disease is raised, confirmatory laboratory SA are available. We can do enzyme activity in leukocyte, plasma, dried blood spot, and molecular genetic analysis. Definite diagnosis of the enzyme and genotype, identifying one new index patient lead on average to a diagnosis of another 5 patients in that family. As we can see, the pedigree of the Dr. Nouria patient, one patient will identify more than 5 patients, almost 7 patients, because or 8. Till now, they are total of them. They are 9 patients in the same family. Hence, the family screening and genetic counseling are imperative after diagnosis and index patient. This is a summarization of how we can diagnose the patient by enzyme activity using a plasma, leukocyte, or on a dried blood spot. It's diagnostic for male, can be diagnosed for female. Normal activity does not rule out the diagnosis. Mutation analysis confirm the diagnosis in male, and it start the diagnosis in female. We need to, also we can do family screening, can be used to demonstrate heterozygote in female. Substrate abundance for GL3 is elevated in the majority of the patient. This should show the percentage of the multidisciplinary approach when they trying to diagnose the sign and symptom of patient with Fabry disease. What is important to early diagnosis Fabry disease? Early diagnosis is essential to provide timely treatment and may help to reduce disease progression. Awareness of Fabry disease is needed to be increased. Clinical consequences of not providing treatment are clear. It will lead to end organ disease, early mortality in both male and female patients, Fabry disease is progressive and eventually life-threatening. It is therefore essential to get an early diagnosis. This current method for diagnosis and assessing patient with Fabry disease. If we have family member with Fabry disease, we can do for them biochemical and genetic analysis. If he is male, we'll measure the plasma urinary GB3 and lyso-GB3 by measuring plasma alpha-galactose alpha activity and confirmation of Fabry disease by genetic analysis of GLA gene. Initial positive diagnosis of Fabry disease referred to tertiary center, where they have baseline evaluation at tertiary center, and then they will manage all the problems they have, and they will start enzyme replacement therapy. If the symptoms suggestive of Fabry disease, like angiokeratoma or acrobarosis, genetic biochemical analysis in female will do for her genetic analysis of GLA gene. It's more important than the enzyme, because sometimes the enzyme level will be normal. And genetic testing is the only way for women to be diagnosed, and then she will go through the same pathway as male. Biomarker in early diagnosis Fabry disease and monitoring of disease progression, the biomarker GB3 and lyso-GB3. Elevated GB3 either in plasma or urine has been used as a diagnostic biomarker, but is a poor indicator of disease progression outcome. So it's a good biomarker, but it doesn't give us about the progression of the disease. Lifetime exposure to lyso-GB3 in plasma correlate with Fabry disease severity and is detectable from an early age. So therapy of Fabry disease either by supportive treatment, supportive treatment and specific treatment. Supportive treatment includes symptoms-based intervention. We can treat pain management, dialysis of the kidney, transplant kidney, cardiac pacing, antidepressant, and hearing aid. Specific therapy including enzyme replacement and with the agalsidase beta or alpha. So optimal care involves both disease-specific and supportive treatment and regular monitoring follow-up with multidisciplinary team experience in the management of Fabry disease. Supportive care, like for pain, we can give anticonvulsant, anti-anginal agent for chest pain, and if the patient have hypertension, we can give ACE inhibitors. For renal disease, we give ACE inhibitors, dialysis, transplantation. Cardiac, we can give anti-arrhythmia and diuretics and pacemaker. Enzyme replacement therapy by agalsidase beta, giving us infusion every 3 weeks, or agalsidase alpha. Both of them are well tolerated and effective to treat the disease. So treatment for Fabry disease, enzyme replacement, correct the underlying enzyme deficiency can slow the disease progression. If we give the enzyme, so the disease will be very slow. Indicate for long treatment, enzyme replacement therapy in patients with a confirmed diagnosis of Fabry disease may be used to treat at home in patients tolerating their infusion well. Of course, not in our country. The treatment under investigation includes substrate reduction, as explained Dr. Amal. It will inhibit the synthesis of glycosphingolipid, or we can use chaperone therapy. It will introduce agent to enhance residual alpha-galactose activity. Or gene therapy study in human have not shown yet progress to date. Still now there is no gene therapy. So Fabry disease, it needs multidisciplinary care. Besides metabolic and geneticists, we need a nephrologist, cardiologist, a gastroenterologist, dermatologist, primary care provider, genetic counselor, and pediatrician. A treatment challenge for Fabry disease, GLO3 accumulation may start as early as in fetal life. Fabry disease affects multiple tissue and body systems. Tissue damage is progressive and can be irreversible if the treatment is late. A window of opportunity for intervention varies with affected tissue or organ system. Why we have to screen patient family for Fabry disease? Because the treatment is available, and Fabry disease diagnosis can take years before the diagnosis. Because it is X-linked, so diagnosis other family is merited for doing genetic counseling and therapeutic intervention. Fabry disease can lead to renal insufficiency, cardiac disease, stroke, and should be considered in every patient with unexplained renal disease, heart disease, cerebrovascular disease. In summary, Fabry disease is a progressive multi-organ life-threatening disease affecting both male and females, but is underdiagnosed. Female may be as severely affected as male. Fabry disease should be suspected in case of renal insufficiency, proteinuria, albuminuria of unexplained cause, left ventricular hypertrophy of unknown etiology, arrhythmia, stroke of unknown etiology, neuropathic pain, GI distress, heat, cold intolerance, especially with a positive family history. So more specific signs include angiokeratoma and corneal verticillata. Testing is straightforward by enzyme activity SA in male and additional DNA testing in female. After confirmation of diagnosis of Fabry disease, screening of the patient family will usually identify more other family affected, maybe 5. The benefit of early diagnosis are particularly compelling because early treatment is critical to achieve the best outcome given the slow progressive nature of the disease. Thank you.
Thank you, Dr. Huda. I have some questions from the audience. The first question is, what are the most signs and investigations required at the level of primary care for children less than 2 years for early detection of Gaucher disease to send to them early for the hospital? Dr. Amal, please.
Okay, thank you for the question. And there is 2 types of the Gaucher disease. We have neuropathic and non-neuropathic. If you have a child with hepatosplenomegaly and pancytopenia, send it to the hospital. Or any developmental delay, send it to the hospital to be seen by genetist or neurologist.
Okay, thank you, Doctor. Yes. There is a question to me, what are the causes of these disorders? Those disorders are inherited, means the parents, for most of the cases, parents are carrier of the disorder and they inherit it to their children. Or maybe one of the parents, like in MPS 2, the mother is a carrier for the gene mutated and it inherited from the mother. So it is inherited disorder. Thank you. There is another question. What is the average life expectancy in patients with Fabry disease and Gaucher disease? Dr. Huda and Dr. Amal, please.
Fabry disease, the average life is 50 years. So they can live only 50 years because they will end with renal dialysis.
Okay.
And they can survive with the renal dialysis, right?
No, they will not survive.
Okay, okay. And for Gaucher disease, Dr. Amal?
Okay, for Gaucher disease, according to the type. Type 1, it's variable. They can live and they can marry and they can get pregnant. The type 1 Gaucher disease. Type 2, less than 2 years. Type 3 is subacute form of neuropathic. They can live to 30 or 40 of age of life.
Okay, thank you. There is a question for everyone. Is there any available community support group in Saudi Arabia for these genetic conditions? Dr. Huda, start please.
There is a local for each hospital. They will do a rare disease day. We are doing توعية يوم تطوعي for unborn metabolism and for also rare disease yearly. We are doing to educate the people about rare disease and also inborn metabolism in all area of Saudi Arabia.
Yes. Okay. And Dr. Amal, what do you think of the same question?
Okay, there is no official group for supporting such disease like outside, but there is a group of mothers who has a child having a metabolic disease. They have a group to them. They are supporting each other, but it's not official.
Okay, my answer, there is no official group, as Dr. Huda and Dr. Amal said, but we usually make days for the parents. We communicate with them, we meet them, and we do some lectures for them in Arabic, and especially for metabolic disorders, we do cooking sessions together with dietitians. Question number 5. Is there any oral replacement for MPS disorders or Gaucher? For MPS, the enzyme replacement is only IV infusion. For Gaucher, Dr. Amal?
For Gaucher, there is as I talked in my talk, there is a miglustat. It's oral for mild to moderate Gaucher disease. But we have in our Middle East severe mutation and severe manifestation. So we're starting by enzyme replacement therapy. Later on in adolescent, we can replace it by the oral medication, miglustat. It's a miglustat.
Thank you. Okay. Thank you. There is a question in Arabic. She's saying أنا حامل لأنيميا الفول، هل تتأثر صحتي إذا تناولت البقوليات والفول؟ طبعا أنيميا الفول is different from our subject, but still it's an inherited disease and X-linked, and it is طبعا هي تأثروا taking بقوليات and فول. There is another question. What is the mechanism of lysosomal storage disease to produce hydrops fetalis? I'll answer this question because in MPS type 7, they might present with hydrops fetalis because there is reduced enzyme to, or deficiency of an enzyme to hydrolyze glycosaminoglycan. And this leads to storage of affects all the tissue and organs and leads to hydrops fetalis. The same mechanism as I told from the beginning of my lecture. There is another question for me. What are the causes of these disorders? The answer is this is an inherited disorder again from the parents, either autosomal recessive or X-linked recessive. Again, there is a question for Dr. Amal. Type 2 Gaucher disease is not for enzyme replacement therapy, right? This is the question.
Yes, there is no benefit to start a patient with Gaucher disease type 2 on the enzyme replacement therapy. They are not responding for that.
Okay, thank you. Any more questions? Thank you, everyone, and we are ready to answer any questions. Thank you for the audience. Thank you for Saudi German Hospital. Thank you for the speakers. Thank you for Dr. Yasser.
Thank you, Dr. Fawzia. Thank you, Dr. Huda, Dr. Amal, all the panelists and all our participants. It was very interesting subject, very comprehensive and wonderful lectures. I'm sure that we will have many to come. We are looking forward to see you on the next Friday webinar and looking for our participants to be a part of the coming event. I need to ask them, all of them, to make sure that they enter their Saudi Commission registration number, their mobile number, their email, so they will be able to get the CME hours on their account, and to provide the feedback for our webinar, of our today's webinar, to be able to improve in the future. Thank you, Dr. Fawzia, Dr. Amal, Dr. Huda. I'm looking forward to see you again.
Thank you very much.
Thank you.
Thank you very much.
Thank you very much.